present the skills of ERCP in such a nice way. Now our next speaker is Dr. Rohit Prasad Yadav. Now he is going to talk about cholangitis and CBD stones. Dr. Rohit, the stage is yours.
He will take all the question and answer after the third question gets over. If you can.
Chairperson, my guru, Bile sir, my seniors and my dear colleagues.
Mic is not working, please.
Is it working, sir? Okay. So respected chairpersons, my guru, Bile Adhikari sir, my seniors, my colleagues, dear friends, good morning. So this is the place where I have spent 16 years of my life, and I have too much emotional attachment with every corner of this institute, and at present I am working in Virat Medical College. So you all know, around 10 to 50% of cases of gallstone is associated with CBD stones, and there still exists controversy regarding the proper management approach. As is evidenced by when you visit national or international conferences, invariably you will get one topic of debate on this topic. And this is not debatable in the conferences, it's debatable in the PubMed also. The moment you write the management of polydopolithiasis, you will get 1386 articles on management of the CBD stone. It itself suggests that the standardization of the treatment of CBD still has not been achieved. The persons who does only ERCP will obviously say that this is the best way of treatment of CBD stone, and surgeons who does only laparoscopic surgery, laparoscopic CBD, he claims that this is the best. I am the person who has little knowledge of both these procedures, so I will try to explain it in unbiased way. So, once we talk about the history, in open era, obviously open CBD exploration was the gold standard. So with the development of the surgical instruments, techniques and experiences, it started from open labs, open CBD exploration 2 in 1970, open cholecystectomy plus ERCP. Thereafter, with emergence of laparoscopic surgery, we started doing laparoscopic cholecystectomy plus ERCP in different settings, either pre-op or post-op. Then after emergence of advanced laparoscopic surgery, surgeons started doing laparoscopic CBD exploration in the single settings instead of multiple settings in ERCP. And since 2008, the lots of technical advancement has occurred in laparoscopic surgery, the audio-visual systems, different type of gadgets, and the side-by-side ERCP is also one of the greatest innovations, and it's lots of development is being done in both these procedures. So previously I used to do open CBD explorations, and at first time 2009 I did laparoscopic CBD explorations, and at that time I didn't have polydoposcope, so I used nephroscope. And I discussed with my friends, till now also my friends are using different type of instrument ranging from flexible to rigid urotoscope. So at present we have options like open CBD exploration, ERCP plus laparoscopic cholecystectomy 2 stages, or some people are doing combined laparoscopic and ERCP in the single setting. I have heard it is done in KIST Medical College, I think. There is one publication also. And while we are fighting the surgeons and the gastroenterologists, slowly the radiologists are coming to play. And now they are claiming that this stone can be managed by radiological interventions. So in this talk, I will mainly focus the commonly practiced one stage or multiple stage procedures. In single stage there is ERCP, either pre-op. In single stage, intraoperative ERCP followed by laparoscopic cholecystectomy or CBD, laparoscopic CBD exploration, be it a transpolydopal or transcystic. In 2 stages, there is pre-op or post-op ERCP followed by laparoscopic cholecystectomy. So what is the common scenario in our part of the world? The moment CBD stone is diagnosed, it is sent to the ERCP center. And what is done, if it is a small stone in the single settings, all the CBD stones will be cleared and patient has to wait for 4 to 6 weeks for laparoscopic cholecystectomy. Or if it's a large stone, you will not be able to retrieve the stone, you have to just pre-cut and stent it. And you have to wait it 4 to 6 weeks. Then you have to do CRE, balloon dilatations, and it may be possible that you will be able to retract the stones or you may not. For that regard, you have to, after retraction, you will be sending the patient back to laparoscopic cholecystectomy or lab CBD explorations. So, what I realized in my practice that my patients are getting too much sufferings, referring here and there, and lots of expenditures. So I thought that instead of referring my patient to the other center, why not I should refer myself to the ERCP center. So I referred myself to the Dhurikhe and I started ERCP learning. This is the journey how I started learning ERCP. So what are the factors which actually influence the optimal management? Depends on the clinical presentation, risk profile of the patient, size and number of the stones, CBD status, gallbladder status, previous abdominal surgery, cost factors and local expertise. Despite that, we have realized, and even there is one publications also, surgeons are reluctant to do laparoscopic CBD explorations. The reason being, it's a time consuming, this is true. And equipments are not available at every hospital. There is lack of skills, there is increased morbidity, especially to the leak. And there may not be a good GI backup in every hospital, and this is a expensive procedures. So it is done by both transcystic and transpolydocotomy approach, especially if the diameter is less than 6 mm, then it's done through transcystic approach. If it's larger than 6 mm, then it's preferably do polydocotomy approach. So how I do it? So the moment we extrude our CBD in the supraduodenal part of the CBD, yes, people do make incision with cold line. There are a variety of techniques, but even I have realized that making a small hole with a pure cut mold cautery will just touch at one point, make a hole that can be extended with a scissor proximally and distally to make the hole in the CBD. And once you irrigate the CBD, you use copious amount of water, and once you release the pressure of irrigation, many stones comes out itself. You don't have to do anything. But if you further proceed, you can insert your polydocoscope and you can nicely visualize both upper and distal part of the CBD. You can such a nice images. To get this type of image in ERCP, you have to use very expensive gadget, cholangioscope. So, if the stones are not coming out just by flushing, you can apply variety of methods, techniques, like just by simply crossing forceps, you can retrieve large stones, or you can insert a basket. So, how I do in my OT setup, even in this case, my polydocoscope are not working, that's why I use bronchoscope. Both these bronchoscope and polydocoscope work on the same principle. If it's a large stone, it can be retrieved by forceps. So after clearing the CBD, so there are different options depending on the expertise of a surgeon. Either you can insert a biliary stent inside, or you can place T-tube, or if you are 100% sure that there is no remaining stone, you can do a primary closure as well. And invariably, I put one abdominal drain because there is possibility of biliary leak. So depending on the size of the stone, diameter of the CBD, and the influence of the cystic duct to CBD, you can choose whether we should go through the transcystic approach or transpolydocotomy. So what is the good thing about the laparoscopic CBD? It's a one-stop shopping. Both polylithiasis and polydouble-lithiasis is treated at the single settings. It is safe, effective, and there is shorter hospital stay. It's good for motivated surgeons. It will improve your surgical skill. You can teach your juniors and motivated surgeons, and it's a low cost. Fewer procedures, fewer admissions is required, and fewer referrals are required. So it's good for health system also. So I have talked about laparoscopic CBD exploration. Let's talk about the ERCP. The moment I saw the ERCP done by Professor Ram Guru, it was fascinating for me. Within minutes, all the CBD stones came out. I thought, oh my God, why I should do laparoscopic surgery? I should learn ERCP and every stone should be removed by the ERCP method. But no. The moment I started learning, I realized that, oh my God, this is very difficult procedures. And it has lots of complications. Even I have observed death after ERCP. It causes a severe pancreatitis, perforation, and hemorrhages as shown by the previous speakers as well. So, obviously in the ERCP, it seems that a simple guide wire goes inside, we do pre-cut, we retrieve the stone by balloon. But the first hurdle, the moment you enter in the duodenum, you will get a variety of ampulas, depending on the morphology and shape. And it has been documented that even the expert endoscopist may fail to cannulate. So, if you are flying in a blue sky, you will see such a beautiful papilla, you will be able to cannulate it very easily. You will do a pre-cut, a stone will come out within minutes, you will stent it. But if it's a large stone, you cannot do it. So you have to do in a different settings. You have to do CRE, balance dialysis, and next setting you can able to retrieve even a large stone followed by stenting. Not only that, the problem does not stop here. The moment you will do cholangiogram, you may get a very large stones with distal CBD strictures or narrow diameter of the CBD, where you will be unable to retrieve the stones. You can get this type of picture of large stones where ERCP is not possible. But having said that, lots of procedures have been developed in ERCP. They are doing different type of crushing mechanism to crush the CBD stone. They apply the intracorporeal and extracorporeal shock therapy. Even laser has come to blast the stone. So all these procedures, depending on the setup, depending on the institution, and almost all stones are they are claiming to remove by ERCP method as well. But obviously, if they fail, you have to go for laparoscopic surgery. So with the increasing size of the stone, there is a drastic fall in the success rate of the CBD clearance. So what is the pros and cons of the ERCP? Obviously, the stone clearance is very high in ERCP as well, 93 to 96%. And cons is obviously patient has to be admitted twice. Additional anesthesia is required, and there is morbidity up to 15% equivalent to laparoscopic surgery. And the most dreadful conditions is pancreatitis, perforation, hemorrhage, cardiopulmonary complications, and mortality up to 1%. Length of stay is longer as compared to laparoscopic CBD expression because patient needs admission twice. It's more expensive. Despite saying that, ERCP has undisputed role in certain cases like primary CBD stones, gallstone pancreatitis, cholangitis, unfit patient, postoperative retained or recurrent stones, especially biliary cirrhosis and coagulopathy. So we have discussed both laparoscopic surgery and ERCP. So who is better? Which is better? So depending on the expertise of the person who is doing it, he claims that this is better. So let's do unbiased analysis and let's go to the PubMed. So there are lots of publications having randomized clinical trials and systemic reviews. So I will discuss only one important article which has combined all these four approaches in single setting laparoscopic surgery, single setting intraoperative ERCP, followed by laparoscopic cholecystectomy, pre-operative ERCP followed by laparoscopic cholecystectomy 2 stages, post-operative ERCP 2 stages. So this is a big meta-analysis considering success rate, overall morbidity, mortality, pancreatitis, biliary leak, overall bleeding, operative time, loss of length of hospital stay, and cost. And they showed this type of result, showing the best one is intraoperative ERCP and laparoscopic cholecystectomy, the single settings, followed by lap CVD exploration, and third one is pre-operative ERCP followed by laparoscopic cholecystectomy, and worse is the post-operative ERCP. Again, it is said that the most success overall is intraoperative ERCP and laparoscopic cholecystectomy, but it is done by very few people. It is said that it is cumbersome position to do in the same sitting because you are doing laparoscopic cholecystectomy in supine position, even you have to turn it in the prone position for the ERCP. So, what is the pros and cons of the single setting that lap CVD and two setting that ERCP plus laparoscopic cholecystectomy, which is most commonly performed in our setup? Obviously, the post-hospital stay and morbidity, there are basically too much of systemic analysis, and overall what I have observed that both these procedures are equivalent in the outcome. Depending on the situation, like ERCP pre-favor in gallstone pancreatitis, post-colic status, stone with coagulopathy, whereas lap CVD prefer in large stones and if there is abnormal luminal anatomy. For patient point of view, both the procedures are similar. For insurance point of view, ERCP is expensive, and for endoscopist point of view, obviously this is preferable. And for so, I am coming to at the end of my presentation. So over the years with the development of lots of development in laparoscopic surgery, the trend in the last decade is toward the minimally invasive procedures. And success and mortality are similar. Lap CVD exploration is late, requires demanding technical skills. Till further study, lap CVD has an advantage over endoscopic therapy in terms of hospital stay and cost. So to conclude, the current meta-analysis suggests the outcomes are equivalent. Lap CVD is effective and safe treatment option for concomitant gallstones and CVD stones regarding long-term and short-term outcomes because it avoids the morbidity mortality associated with ERCP and maintains the integrity of the sphincter foci. With more refinement in the equipment and the technique, it is possible that lap CVD may become the gold standard treatment for gallstones, CVD stones. Certainly, ERCP is irreversible because it can release biliary obstruction in acute suppurative obstructive cholangitis in a timely fashion, which causes a patient to tolerate the surgery more easily. Therefore, optimal management of patient with CVD stone depends on the condition of the patient, expertise of the operators, and local research is largely dictated by the institutional expertise, individual physician preference, as against the outcome data from controlled trials. So my suggestion is, every surgeon should learn basic endoscopy and colonoscopy. Surgeons should be able to do laparoscopy CVD exploration. Surgeons should learn ERCP. And CVD stone should be under armamentarium of the surgeons because this is bread and butter for every surgeon. Thank you.